+4. And that's why I depend in a residual refractive error to be on a preferable near vision for each patient. Parameter intraoperative surgeries were all done under topical anesthesia, and that was one of the important things here. By same surgeons, cornea incision were performed in the steep axis of all eyes, having astigmatism less than 1 diopter. Limbo relaxing incision were performed in eyes with a corneal astigmatism between 1 and 1.5 diopter. Viscoelastic material, I'm using sodium hyaluronate with low molecular weight and high molecular weight, so it's working as a cohesive and dispersive. But in all these surgeries, I removed all the viscoelastic from under the lens to make sure for the stability of this lens. In order to keep the central optic zone of the lens in the visual axis of the patients were asked to focus on the microscope light, and the reflex of the light was aimed to center of the optical zone of the lens. The controversy here around how we can find out the visual axis on a corneal map or whatever. Now, few surgeons, they are using intraoperative corneal map. And that's intraoperative corneal map, they are selecting the geometrical and they are marking that geometrical center, and intraoperatively, especially if they are doing the surgery under a local anesthesia injection or general anesthesia, they are centering the optical zone to the geometrical center. That's one of the ways. Definitely it will solve the problem for local anesthesia injection and general anesthesia. But what I did here is that I depend on the cooperation of the patients by doing the surgery in topical anesthesia and asking them to focus on the reflex light. Parameter analyzed 3 months post-operative include uncorrected distance visual acuity, and our target was 20/20 or 6x, 1. Uncorrected near visual acuity, our target was Jagger 3, depending on the preferable near point for the patients. Subjective visual symptoms including the night halos. The result. Hyperopic